So everyone, it's my pleasure to introduce Zachary Nelson, who's a PharmD who is going to be presenting to us on the prevention and management of UTIs and what the WikiGuidelines consensus statement tells us. Zachary has a clinical and research expertise spanning emergency medicine, infectious diseases, and epidemiology, bridging patient care and population health, all perfect attributes supporting activity on one of these guidelines. He served as lead author on the UTI WikiGuideline that was published in November 2024. And so now we're going to hear all about those. Zachary, pleasure to have you involved, and I really look forward to your presentation. Thank you.
So yeah, thanks, Emily, for a great introduction on the WikiGuideline front. UTI, I think, was one of the first WikiGuidelines that was really more broadly applicable to the medical community. Certainly endocarditis and osteomyelitis often involve the care of an infectious diseases clinician, at least here in the States. So this was an exciting foray into a disease state which has a significant spectrum of presentations and management opportunities. So excited to share some of the highlights of this guideline with you today. I don't have any disclosures to report. So the WikiGuidelines, as Emily alluded to, is a crowdsourced endeavor. So this amounted to 54 experts across 12 countries representing 5 continents. You know, ultimately, these are mostly high-income countries that are represented in this sample, but certainly we would like more representation from low and middle-income countries. And we discussed 37 questions, and I think that speaks to the breadth and the spectrum of UTI across both adults and pediatric patients. We split it into some easier to digest domains, including prevention, diagnosis, empiric and definitive treatment, some stewardship, and then special populations. I was lucky enough to be able to co-chair this with Dr. Alfredo Mena-Lora, who is an ID physician and professor at the University of Illinois at Chicago. We reviewed lots and lots of studies and included 914 in the supplements. This took us about 1.5 years, which is a little bit shorter than the process that Nico and colleagues had to endure for the IDSA setting. So I wanted to make sure to touch base on the recommendations that we are able to make clearly. So as Emily alluded to, it's going to be assigned either clear recommendation or clinical review based on the quality of the evidence. And I wanted to make sure to touch on all of the clear recommendations that we were able to come to. So there were 37 questions, and we were able to clearly recommend 6 times out of 37. So that just speaks to the fact that we want to ensure fidelity to that charter and make sure that we are only making clear recommendations when it meets that criteria. So in fact, many of them have to do with urinary tract infection prevention. So the first one came as a surprise to us, as I think that cranberry products often have a reputation as being a money sink, or perhaps a way of trying something that we don't really know if it works. But we were able to actually find 2 RCTs in which there were women and children included, even some who had recurrent UTIs that benefited from the addition of cranberry products in terms of reducing subsequent UTIs. The one caveat being that there are these active ingredients called proanthocyanidins. I practiced that a couple of times. With at least 36 milligrams of that active ingredient in it. So I think that's a big issue to keep in mind with these cranberry products, is that not everyone is the same. And at least here in the States, these are not regulated by the FDA. And so you're not really entirely sure what you're getting, but to increase the chances of it actually doing some good, looking for at least 36 milligrams of these of the active ingredient is something to consider. Notably, we didn't see enough evidence to fully clearly recommend cranberry in every population. So unfortunately, our populations that often experience a lot of UTIs, so our older adults over 65 And then those with some bladder emptying problems or urinary retention, we weren't able to make a clear recommendation for those populations specifically. The next clear recommendation, and this is by far the most overwhelmingly clear recommendation we can make, and that's for vaginal estrogen. So this is supported with 31 prospective studies total, including 30 RCTs since 1990. So we can clearly recommend in order to reduce the incidence of recurrent UTI in postmenopausal patients. And there's a couple of different ways that we can do this. Most oftentimes it's split into two to three times per week administration. A lot of times our patients seem to have a hard time with the entire applicator full, and we hear this from our urology colleagues as well. And so oftentimes, a small amount each night can sometimes make that administration a little bit easier. And so really, it has effects beyond simply just preventing UTIs. It has, in a lot of these cases, we're using it in postmenopausal women, which have a lot of changes and perhaps weak pelvic floors and other physiology that results in them being more predisposed to UTIs. So we can see that topical estrogen has been shown to decrease, of course, the uropathogens that colonize the vaginal flora, but also, the vaginal vulvar atrophy symptoms, cystometric opacity, the volume at which urgency to void is felt. So a lot of things that might cause urinary symptoms that may not even be due to an infection. So not only can these prevent true UTIs, but I think it would be a reasonable extension to say that perhaps these can solve some non-infectious urinary syndromes that these postmenopausal women suffer from. I think safety is a big component of this, that people are nervous to use it, but there's a lot of reassuring data from the Women's Health Initiative and some other large cohort studies that don't demonstrate an association between vaginal estrogen and some of the things that we often worry about, like breast cancer, thromboembolism, or coronary artery disease. So the last one in prevention is oral methenamine, and we found 2 randomized controlled trials to support its use in patients with, quote, intact bladder anatomy. And what that means, it was very vaguely defined. So choose your own adventure on that. But it was found to be non-inferior to daily continuous antimicrobial prophylaxis in these studies. So as a reminder, this breaks down into formaldehyde and ammonia, which have bacteriostatic effects. So moving on to diagnosis, and really this is going to be a little bit more of a bridge to the IDSA too, but really classification, I think. A lot of the diagnostic components of the guideline were clinical reviews, things like what is the role of the urine culture, what is the role of the urinalysis in the workup of a febrile patient in the hospital, those types of things that we weren't able to come to definitive conclusions on. So there is a lot of that, a lot of great, interesting discussion about those important topics. But I wanted to, of course, talk about the elephant in the room, which is sort of the changing terminology. And so the definition of complexity has sort of evolved now over time, and it really differs between whatever group of guidelines that you're looking at. So in certain guidelines, it will reflect patient-specific factors that might influence treatment failure. In others, and especially in the newer ones, it reflects more the characteristics of the infection, such as the anatomic location or severity. And in general, the thought is that these more complicated infections require a higher intensity of treatment and or duration of treatment. But we have data that says that, for example, a female who is 65 years and 1 day old isn't necessarily more complicated than somebody who is 40 years old in terms of the need for a more intense treatment or a longer duration of treatment. So this is just getting at what I was talking about in terms of the formal definitions of complicated that are included in guidelines, and they vary quite significantly. The wiki guidelines really essentially don't necessarily endorse a specific classification, but really instead encourage precise terminology. So really trying to describe the infection by its severity and anatomical location, which happens to coincide with the new definition of complicated that IDSA put out recently. But I think when we think about what is complicated to one clinician versus another, it can be different. And as a clinician, I worry that people may not know that the definition changed, or, of course, not know the data behind whether or not a 66-year-old woman who would be considered complicated historically might not need a longer duration of treatment. And in fact, maybe we might be doing some harm in that setting. So calling the infection what it is based on the precise or as detailed terminology as we can get, and then treat based on the data that supports that specific type of infection. Empiric treatment. So this is a very similar approach, and Barbara Trotner, which is the lead author of the IDSA guideline with Nico, and I presented at ID Week about this, and it's a very similar approach. So I'm not going to belabor this because the 4-step approach that Nico is going to talk about is very similar to the WikiGuidelines approach, but essentially identifying the infectious syndrome, the severity of that syndrome. The big difference is WikiGuidelines sort of differentiates between treatment settings, recognizing that there are going to be patients in either case who might be treated either inpatient or outpatient, depending on specific circumstances. And so there's, of course, always this spectrum of patients within each big bucket to keep in mind. And then we assess whether or not there's risk factors for multi-drug resistant organisms and pick from some selected preferred antibiotics after that. And I think it's important to talk about multi-drug resistant organisms. And this, again, when we looked at whether or not we can make a clear recommendation on which risk factors are truly risk factors, we weren't able to find any. And the reason is that there's no validated models to predict this. There's a lot of heterogeneous definitions from observational studies. And using ESBLs as an example, prior hospitalization, recent antibiotic use, or a history of UTI are commonly considered to be risk factors for predicting a UTI due to a multi-drug resistant organism. But a lot of these ignore the epidemiologic context, right? So prevalence of ESBLs in the States, the coasts have a much higher rate of ESBLs amongst E. coli than we do here in the Midwest. And so that's important probably. How recent was the antibiotic use? Depends who you ask what recent means. Was it within 90 days? Was it within 30 days? Does that matter? Does it matter what antibiotic they were put on before? It seems to, and the IDSA guideline does a nice job of explaining specifically with fluoroquinolones about how recent exposure to that might influence that. So the reality is that we don't really know the people, and there's a lot of confounders that sort of distort those associations. And so looking at severity of illness and prior culture data within the last 12 months or so should be the primary drivers of or would be the most reasonable drivers on empiric treatment towards MDROs. In terms of definitive treatment, I think one of the nice parts about the WikiGuideline is that we do sort of an in-depth discussion about what truly is clinical efficacy. And certainly in the States and in Europe, we struggle with this sort of requirement, if you will, regulatory requirement to meet both clinical and microbiologic cure demands in terms of defining clinical success. And so we really struggle with the concept of clinical success and treatment failure, especially in the context of my patient's clinical symptoms are better, but they still have bacteria in their urine. So this would generate what they call that composite or responder endpoint failure. It would be considered treatment failure even though their clinical symptoms got better. And we don't really know the significance of that. And we went into a lot of detail to discuss what the implications of that might be. Recognizing that the urine is not sterile, and that ASB or asymptomatic bacteria is often associated with other risk factors for having recurrences down the line. So it really brings into question that significance of finding asymptomatic bacteria in a follow-up culture that we wouldn't normally do in clinical practice. And this is just, again, to illustrate the fact that there are a lot of specific characteristics of patients that are associated with treatment failure in the observational literature that don't necessarily pan out when you just take a look at the high quality randomized trials. So for example, older age, which is heterogeneously defined, of course, amongst the observational studies, that very routinely is associated with clinical failure for cystitis. However, if we pool the RCTs of women over 65 with cystitis, comparing a short versus long duration, we don't see that there's a difference in terms of a short versus long duration for persistent UTI or clinical failure. So they weren't more likely to fail in this sort of randomized, higher quality design, but they are, of course, in those observational studies that are subject to confounding. In terms of using oral antibiotics, we weren't able to clearly recommend using oral antibiotics from the front. There just simply aren't any RCTs. Of course, while we were at ID Week, there was a press release. And so oral tebipenem, which is an oral carbapenem, new to us, was shown to be non-inferior to IV, but that's the only RCT. And so, of course, we still wouldn't be able to make a clear recommendation. But there were 4, and it's the same 4 that the IDSA guideline found, that allow us to clearly recommend to transition to oral antibiotics. Most of those studies did so after 3 to 4 days of IV treatment. And I think we should be reassured by data in pediatrics. There's actually multiple RCTs in pediatrics that use all oral regimens with no difference shown between all oral versus IV, then transitional to oral. And a lot of our experience with other systemic infections and using oral antibiotics. So this is something that is a big area for emphasis. But really choosing the right one is probably very important, especially in the case of more severe infections like bacteremia, pyelonephritis, prostatitis, those types of things. And unfortunately, a lot of the data thus far sort of separates the agents into highly or low bioavailability groups. And so I think this is just sort of a public service announcement that it's more than just bioavailability. It has to do with whether or not we can meet our defined pharmacokinetic and pharmacodynamic targets. So for cephalosporins, for example, we want to achieve about 60 to 70% of the dosing interval above the MIC. And we take cefprozil here, which is a second generation cephalosporin available here in the States, has high bioavailability, but the wild type MICs for E. coli are actually quite high. And so even if we, dose this at our usual dosing or even twice the normal dose, we're only achieving about 12 to 25% above the MIC for the dosing interval. So that's not even close to 60 to 70%. Where we use cefodoxime, a third generation oral cephalosporin available here in the States with low to medium bioavailability, that actually gets us a lot closer. And so in many of these studies that are out there that sort of compare beta-lactams versus not, most of which are observational in nature, Balance Plus is coming, which is exciting, but the selection of the beta-lactam and the dosing, if you look into those things, is very suboptimal, and they still look fairly similar to some of the comparators. So getting to duration, so again, clear recommendations for some and clinical review for others. One thing to note, we were not able to come to a clear recommendation for beta-lactams for cystitis due to the heterogeneity in the drugs chosen and the dosing chosen. For pyelonephritis, we were able to make clear recommendations for fluoroquinolones for 5 days and dose-optimized beta-lactams for 7 days. Febrile UTI and catheter-associated UTIs are areas for future research. We were unable to make clear recommendations for either of those. Febrile UTI is another example of a clinical syndrome in which there's probably a spectrum of patients, especially in men, who have some degree of potential prostate involvement. But The RCTs out there are just insufficient to make a clear recommendation, but certainly ProstaShort was encouraging that a very, very small dose of ofloxacin achieved 96% clinical cure in the 7-day arm in that study. So again, a lot of that regulatory stuff is coming back in terms of driving the clinical outcomes, and essentially this excess asymptomatic bacteria at follow-up led to this inferior finding. And then catheter, these really are not rigorously evaluated in RCTs, and often they're subgroups. And so we really have a lot to learn about CAUTI. Gram-negative bacteremia from a GU source, there's plenty of evidence now to suggest that 7 days after source control is the optimal duration of treatment. And again, just emphasizing that there are specific classes and drugs within classes that are probably the better choices based on their favorable exposures from a PK/PD standpoint. And then I wanted just to wrap up by addressing that last clear recommendation that we were able to make, and that was for patients with certain urologic disorders. So we were able to clearly recommend no antibiotics for routine cystoscopy and urodynamic studies, cystoscopic stent insertion or removal, and nephrostomy tube placement. We found enough data to say all of that clearly. We also were able to suggest or recommend clearly the use of a single dose of surgical prophylaxis antibiotics for patients undergoing percutaneous nephrolithotomies. And so that was the last clear recommendation. So again, we still have lots to learn about one of the most common infections ever. We were only able to generate 6 clear recommendations out of 37. And, I think oftentimes the burden of proof lies on these new practices without critical assessment of these historical behaviors. And Emily touched on this a little bit, but I think this is a great example of how little historical practice tells us in UTI.
Zachary, sorry, I was just really enjoying all of your discussion about PK/PD and special patient populations, topics dear to my heart. And so thank you very much for that. And I think the comments about bioavailability were just spot on, and I thought that was great learning for everyone. Could I just see if anyone in the room has a question that they'd like to quickly ask Zachary before we move on to Nico? No? So what we'll do is we will move on to Nico. Thank you very much, Zachary. You're going to hang around for a little bit of discussion?
Yes.
Perfect. Thank you very much.